We're going to begin with the presentation. So I will let Dr. Gregory introduce himself. To start, he's a family physician at Carilion Clinic. Dr. Gregory, to you.
Thank you all. So as you all are giving me a sense of where you're located, I'm Dave Gregory. I'm a family physician. I've been an academic family physician for 27 years. I have a background in military medicine originally and global medicine, including advanced life support obstetrics leadership, various things with maternity care and family medicine and in health systems. And I appreciate everyone joining us today. Welcome. The title of the presentation today is how could family physicians help with reducing or improving maternity health? So we've got a lot of folks from all over Virginia. I'd like to proceed along, and I've got to figure out how to advance the slides. So can you help with that at all, Sabrina, or am I supposed to do that?
I think if you go into the screen sharing and then change the window that you're sharing just for now. Okay.
I am doing that. You tell me if it's working for you. Yep. Okay. Is this it? Share. Can you see my screen?
It's still showing Menti.
Okay. This is all a little new for me, so hang tight. Okay. We may have some difficulties here. Hang tight for us for a little bit. It's supposed to be all in one presentation, so hang tight. I'm going to get out of there, see if I can advance in another manner. Okay. Not as straightforward as I'd like it to be.
If you hit like the space bar or something, does it advance the slide in Menti?
No, it doesn't. Okay. I'm pretty sure we're here. I just cannot advance my slides.
You want to try their arrow keys?
I've tried.
Oh, okay.
Yeah. Maybe this one? Nope. All right. I'm going to practice here for a little bit. Well, while I'm trying to figure out the technical errors here, I just want to let you know that the topic of our presentation is meant to kind of get you all accustomed to what a family physician is, how a family physician values care, the things that a family physician could contribute to maternity care in Virginia, and ways in which a family physician could be engaged in your local care to help with maternity health. And if I can figure out how to advance my slides, I can show you a little more information. So hang tight 1 second. I'm going to get out and get back in. If I can, hang tight. And you all still see my screen?
Yep.
Good. All right. I'm going to pray this works for us. It's still up. There we go. All right.
Awesome.
So there we are. Now it's finally working. So there we are. Here are our objectives I just reviewed for you. I have a few disclosures. I am a family physician. I work with Carilion Clinic. I'm a professor at Virginia Tech School of Medicine. I am the VAFP, Virginia Academy of Family Physicians president right now. I do receive a stipend from them, but my presentation doesn't represent any of those entities. I am primarily presenting from the lens of family medicine, how family physicians could be better utilized for maternity health within Virginia. There is going to be perhaps a brief mention of some off-label use of some pharmacologics for postpartum hemorrhage, but otherwise it's primarily not about pharmaceuticals. So for my benefit and for our audience, if you could share maybe your primary role in maternal health in your location where you are, that would be helpful. Excellent. Good. About 14 respondents here. Great. It's good to see who's in the audience and who we're speaking with. Excellent. Keep it coming if you can. Good. So one of the things you're going to find as we discuss this topic is, in general, family physicians work with everyone here that is listed in some way or manner. But you may find that we sometimes have a hard time engaging. And so I like that I'm able to see you all and hear your perspectives. So thank you for adding. Now, it looks like we've got a lot of disciplines and a lot of background folks. Excellent. So I'm going to move forward. Can you share with me the medical specialty that you perhaps work with the most? Okay. Quite a few obstetrics, a few pediatrics, neonatal, other specialties. Okay. So we're getting a few neonatal folks. Excellent. Good. So it's a mix of folks, perhaps in the realm of what we deal with maternal health. But I noticed not a lot of family medicine folks primarily working with you. And that's not unusual. The family physicians work in a lot of different locations. We're often a brief interloper in neonatal realms, labor and delivery realms, and social work realms in the hospital. So for each of you, you might see a family doc every so often, but you don't work with us primarily. And that makes it a little difficult to engage with you and to understand one another. So I want to just highlight that and move forward. So family medicine, many of you may not realize, I don't see many physicians in the audience, is a specialty. We're not general practitioners. We are residency trained family docs who graduated medical school just like any other board certified physician. We go through residency training, we get board certified, and our specialty is what I would refer to as an uber generalist specialty. So there are generalist specialties that are general surgery, maybe general OB, maybe general outpatient primary care pediatrics, or general internal medicine. Those are all things that are general specialties. And then we have a lot of medical specialties that are subspecialties of the general specialty. And a lot of folks don't realize what that is, but every board certified general specialist is a specialist. There may not be a subspecialist, but family medicine docs tend to be what I refer to as the generalist of general specialties. And so as you consider this, just realize that our scope includes a lot of those general specialty scopes. our specialty is around 53 years old. It's not the newest specialty. It's not the oldest specialty. We have a residency training program that is 3 years mandatory, sometimes 4 in certain locations. It's primarily outpatient, but it includes a lot of things that are rotational, and many of you might see family docs in training in your residency program in your hospital, as an example, or perhaps rotating through a clinic that you are located in. It includes maternity care as part of the broad spectrum of family medicine, and that includes mostly things related with prenatal care and mostly related with trying to understand the emergencies and potential urgencies of maternal care. When residents graduate, they get board certified, hopefully, and they start practicing. And very few, as we discussed, go into maternal care specifically. But not just because you don't do OB, as they say, doesn't mean you're not involved with women who are pregnant. And so the principles of family medicine are very broad. We generally think of ourselves as primarily compassionate, comprehensive, continuous relating docs who are emotionally connected, not separated from our patients and their families, and who are lifelong trying to improve. And that's kind of unique to our specialty. We were the first specialty to have maintenance of certification and requirements for recertification. We were the first specialty to involve quality improvement in our training, and we are the first specialty to embed behavioral health in our training. So we tend to be maybe high touch, low tech. And as a result, we tend to be generally pretty good with taking care of patients in bedside manner. As a result, we sometimes looked at as not the highest in terms of procedural practicing docs. And that becomes a little bit of a misunderstanding for many. So what this means is that we take care of not just simple things, but we take care of a lot of complex things. And as a result of that, we do ongoing care. And we're the person who basically says it's not part of my specialty, rarely, because everything could be included, but we have to know our limits. And as a result of that, my own mother, until she died not too long ago, didn't understand what I did. And I've been doing it for 27 years. So we are easily misunderstood in our scope. We're geographically separated in some ways because we're mostly outpatient. We have what I refer to as a quixotic, relational driven practice that's not transactional or fee for service. And we tend to be given a lot of unpaid or underpaid administrative roles that are listed ad nauseum there. And we are not well paid in relationship to others with similar billing. So it's tough to recruit us, and it's hard to retain us. So lots of barriers, perhaps, to your engagement with us and understanding us. What could family physicians offer maternal care? Well, we are really good in our training and in our experience in understanding our community, finding and filling gaps within the community. We're able to care for up to 90% of patients, 90% of the time, and we're also supposed to be very good at understanding the 10% we can't care for, as opposed to not knowing that 10%. And if you had to have one doc, one clinician, perhaps in a rural community, it might be a family doc who would best fill most of those gaps. We are, as I said, low tech, high touch, which means that we tend to reduce cost and we tend to be very sensitive to cost, but we also are very selective in what we do use technologically. Many of you in the audience are aware, though, that we have a slowly building and ongoing building crisis. You may be familiar with how labor and deliveries have costs that are difficult to recoup. You may be familiar with the consolidative efforts to improve volume and experience into certain centers. You may be aware that there are financial margins that are difficult to meet in health systems, and labor and deliveries are fixed costs when it comes to that. And with lowered volumes in certain places, especially rural, it's been difficult to recruit providers, clinicians, and delivering caregivers in those areas. especially in rural settings where perhaps there might be less than 100 deliveries and less than 4 delivering providers. And family physicians through all of that have been less involved over time in maternal care, partially for costs of malpractice, possibly for the geographic separation. So the effect on rural hospitals is that eventually, not just because family docs are less involved, but less costs are shared, is that labor and deliveries and hospitals with labor and deliveries are closing in rural areas. We've had about 2 hospitals or labor and deliveries close nationwide per year over the last 30 years, and Virginia alone has lost about 5 rural labor and deliveries in the last 20 years. Even our critical access hospitals in Virginia are not equipped with labor and deliveries. And most states across the nation have no labor and delivery in a critical access hospital. The states that have critical access hospitals with labor and deliveries tend to be in the Midwest, and they have a slightly different approach to critical access in that part of the US. With the loss of labor and deliveries, rural patients have to travel, as you can imagine, further, not just further because they live in a rural area, but further to another county or another county two counties away for their prenatal visits, for ultrasounds, for consultations, for triage, for whatever usual things you might see on labor and delivery, and for the next closest ACOG level of maternal care. This also risks a lot of things, as you can imagine: poor prenatal care adherence, less visits, less care, less monitoring. They may deliver on the way to labor and delivery, and they may deliver in a hospital without a labor and delivery. So we know that looking at hospitals that are not adjacent or adjacent to counties where there is or is not a labor and delivery, those that are not adjacent to urban areas with labor and delivery tend to have out-of-hospital births, tend to have births in hospitals without labor and deliveries, and tend to have more preterm births in that first year after labor and delivery closes. And even being adjacent to an urban area with a labor and delivery does not prevent a birth in a hospital without a labor and delivery. So it's kind of unique to just losing a labor and delivery. We have outcomes in such areas that are not ideal for maternal health. These areas are referred to often as maternity care deserts, and they generally are believed to increase risk for things like untreated eclampsia, precipitous deliveries, undertreated hemorrhages, maternal death, preterm birth, birth asphyxia and complications associated, and even neonatal death. So these are all things that we're very interested at VNPC in impacting and reducing, and yet we have maternity care deserts building in Virginia as we speak. You may be familiar with ACOG levels of maternal care. In places, counties where there is no labor and delivery or a hospital with a labor and delivery, that is not included as a level of maternal care according to ACOG. So you might consider that what I refer to as a level 0. So a maternal care desert is a level 0 if you want to refer to it, but that's not an ACOG definition. It's just my way of saying it. And so as a result, we've got a lot of level 0s in Virginia. If you look throughout the US, March of Dimes has about half of US counties having inadequate access, and about 36%, more than a third of counties in the US have no obstetric unit and are officially called a maternity care desert. An additional 10% have low access, which means they have limited prenatal care access, perhaps just a provider in a clinic. That's throughout the US. That includes Alaska, that includes Hawaii, that includes every county in the US. If you look in Virginia, it's not much better. It's actually very similar. About half of our counties have inadequate access, about a quarter have a maternity care desert, and a little bit more than 10% have low access to care. So we're about average, maybe a little bit worse if you think about the total percent of reduced access. If you look at the map that March of Dimes puts out, and many of you might have seen this, it's worth knowing that 81% of maternity care deserts are in what we've referred to as rural areas of the US. You can almost look at a population map and see that maternity care deserts in red here are the low population areas. You might say, well, that's understandable. Not a lot of people live in those counties, so no big deal. They just have to travel another county away. Problem is, this number of red counties is building. If you look at what's been kind of viewed as a trend from 2017 to 2020, the latest data, we did actually increase our OB and certified nurse midwives in the US by about 1.7%, not a big increase. But in that same interval, we saw a reduced rural percentage of providers practicing in these rural centers. So the number of maternity care deserts, if those trends continue, is going up. Now, I might suggest you study the map a little bit and just kind of get a sense of what states, if you know geography, maybe have the most amount of maternity care deserts. And on the next slide here, I'm going to ask for you to give us feedback on a few states, perhaps you can name, that have the most maternity care deserts. And if you're not responding, you might have a hard time remembering what the map looked like. Kansas. Yep. It may not be home. Texas for sure. Yep. Southern Illinois, more than Northern Illinois for sure. Nevada, Texas, Oklahoma, all of these are primarily Midwest states. Ohio a bit, yes. So the trend is mostly Midwest. Virginia is an interesting one. We'll show you that in a moment. So yes, I think you guys are seeing the red is mostly in the Midwest. Alaska is a big state and it's got a lot of red, but yes, Midwest. But something's missing. This map is not including something. And I'm wondering if anyone here can kind of think about what's in the map, understand this a little bit, and figure out what's missing. Any ideas? This is a little bit of a stumper. It's okay if you don't know. Guess what I'm thinking? I see one answer, two answers. I'm not sure I see what the answers are, but we'll see what they show. All right, a couple of answers here. Access to peds and neonatal care might be missing. Populations, mental health resources, FPs and midwives. So in all reality, midwives are included in the data, but family physicians are not included in the March of Dimes data. And so that's a unique little thing. It kind of reflects how perhaps family physicians are not as engaged in these issues with March of Dimes in this example, but in our own worlds as family physicians, we may be. So yeah, the March of Dimes excludes family physicians from the data. Certified nurse midwives are included in this data, but the March of Dimes did not reach out to verify family physicians delivering. If you include family physicians, which the Robert Graham Center did in this map, you'll notice that the maternity care deserts in the Midwest are significantly reduced. They're not gone, but they're significantly less. And you'll notice if you look at the data that around 40% of counties are delivering family docs. and more than half of the non-metro center maternity care deserts are delivered by FPs. And we are the sole source for delivery in about 16% of maternity care deserts. So without that data, it looks a lot worse, but when you include us, it looks a little better, at least in the Midwest. There are several counties, primarily in the Midwest and the Western states, where family physicians are the only delivering docs and or clinicians. And the problem with this, and you'll see a little bit more advanced part of the trend, is in Virginia, a little different. Nationwide, the trend is that is getting worse. Less family docs are being trained and being prepared to deliver that care, and less family docs are able to care for rural areas as they have in past. And if we look at the Virginia data, March of Dimes on your left and Robert Graham Center data on your right, including the family docs in Virginia, you'll notice that there are less maternity care deserts with family docs in Virginia, but it's not as substantial as it is in the Midwest. And if you look at the trend over time in Virginia, several years ago, several decades ago, family docs were delivering, and not as many are now. And that's part of the reason in Virginia we're not contributing perhaps as much as we would in the Midwest. If you look back in the US in 1969, when our specialty was founded, over half of family docs delivered babies. In 2008, it was only 25%. And most of those were the Midwest states. And just a few years later, it was under 20%, still primarily in the Midwest states. And then you look at just a couple years later, a couple years ago, only 8% of family docs in the US deliver babies, and they're mostly in the Midwest states. When you look at that level 0 maternal care, maternity care definition that I gave you, those are areas where in maternity care deserts, there's no place that's anticipating routine care. They're not even thinking or planning basic delivery care. They're just dealing with what comes to them. They might see maternity care patients incidentally for non-maternal or obstetric issues, and they may see them for urgent or emergent issues that need to be addressed, but they're not planning specifically for that as like a labor and delivery would. This is mostly where family docs are usually caring for patients. In rural places like that, it's maybe a few nurse practitioners, maybe a few PAs, but it's primarily family docs. And it's more than half of the US's geography. So it's a pretty significant gap. So how could family physicians help with this? Well, we've been disengaged perhaps, and that's not necessarily purposeful. It's just a fact. By re-engaging us alongside other disciplines and specialties and aspects to force multiply, we could be, and we are probably the experts in those gaps in those counties. So we could help by understanding and sharing those understandings and maybe filling some gaps. So you may have some ideas on how to better engage us. Thought you could share those. All right, as we get some answers coming in, I'll display those. Got one answer here, a couple of them. All right, we'll see what we have here. So maybe a rotation in a local health department to help family docs understand what's going on, perhaps exchange ideas. Legislation, have family physicians at the table, perhaps. Develop nurse corps to augment the rural care. incentives, perhaps in some manner. I don't know exactly what that means. You might refer to finances or billing or changing how things are. We're also in a primary care crisis, not just a maternal health crisis. So we're pulled in many directions. So these are all good ideas. But as you think about us trying to fill gaps, know that gaps are getting bigger and our numbers are not. So we're doing our best. And that's kind of what this is about. So you may be familiar with some family docs who deliver babies, and I'm one of them. I deliver babies, been doing it for 27 years. I academically am about trying to build that number of docs willing to take care of prenatal care, not necessarily delivering. Our objectives in general residency training are here. Most family docs have a 2-month rotation, split up at some point in the year, along with a maternity care experience from their own patient care panel in their own clinic. And we have generally one family doc like myself and most residency programs or more, trying to model that and trying to build that interest and make sure that family docs don't run away from pregnant patients, is how I say. There are some of us who have extra experience. Someone like myself, you might have a fellowship experience or extra delivering experience. There are fellowships out there. They're primarily meant to build the cadre of people like me to keep the sustainability of maternal care in our specialty. We have over 2,400 family docs in Virginia. So I'm just wondering if any of you would estimate how many of us deliver babies in Virginia. And you can choose by number or percent. Couple of guesses, few guesses. Okay. So we got about 10 of you, 12 of you or so responding. Excellent. I think most of you think it's somewhere between 50 and 100, 50 and 99 of us deliver babies. You may recall that the national number in 2021, I believe, was 8% nationally, mostly 15% of family docs in the Midwest. In Virginia, it is less than 1%. There are only 20 to 24 of us delivering babies in Virginia presently. And they are primarily, if not exclusively, located in residency programs. So Virginia is way behind in the number of family docs doing this work. And it may be another reason why there's less engagement, because we just don't have as many of us that are as focused in this manner. So, through high quality training, perhaps improvements in training, access to training opportunities, we could be better force multiplying to add to the number of people working in these realms and contributing to these efforts. We are a part of a big community in Virginia, and VNPC connects us, but there are very few of us in family physicians who do this work. So that's one opportunity as well, that we could help a little bit more, and we certainly can't do that alone. So it's all about getting extra training. Those of us involved with deliveries in the audience, you might think back a little bit about, gosh, what if suddenly you, for whatever reason, maybe malpractice costs, maybe just your labor and delivery closed, you suddenly were not involved with delivering babies. And you're not seeing pregnancy-related issues because you moved into a primarily outpatient practice like a family doc. And you've not spoken with anyone who delivers babies because geographically you're separated and you're further away. You don't have any of your tools. You don't have any of your monitoring in your clinic. You don't have any ultrasound ability. You don't have any meds that you normally would use in labor and delivery. And yet you're rural. And you're rural and you don't know what's coming in your door. And then imagine a pregnant patient arrives. And they're symptomatic for something that could be obstetric or not, maybe a headache or abdominal pain, but you have no records because you've not been engaging with labor and delivery or anyone in prenatal care. You have nothing sent to you. You're on a different EMR, perhaps. You have no prenatal labs. You have no reports. I'm wondering, perhaps the better answer to this question is how you would feel in this situation. Don't answer barriers. How would you feel if you were in that situation? Getting a couple of answers here. Isolated, lost, helpless, reasonable, ill-equipped, uncomfortable. Yeah. And so, when we talk about family docs being involved with maternity care, keep in mind, many of these docs have delivered babies before. Many of these docs have done prenatal care, maybe for decades, and yet they haven't been doing it recently. And they don't have the connections geographically or relationally that they used to have. And so they're exactly helpless, lost, isolated, uncomfortable, appropriately so. And so just recognizing that and knowing that that's a barrier to us getting involved and re-involved, re-engaged. Family docs who are rural, and you can imagine anyone who's kind of geographically isolated, dealing with emergencies or urgencies, we're primarily assuming the responsibility to identify, stabilize, communicate, and transport patients to the definitive care they need. The role is not to deliver a baby if we want to in a clinic. That's not the point. It's not the best thing for most patients, but sometimes they show up, precipitously, and clinics may or may not be well prepared for that, especially if they've not been engaging in this care. So keeping that in mind. You may be familiar, as I have in my career, with many models out there that look at how rural sources of care can relate with other sources of care, network, and collaborate. And when you look at all across the world, there are many studies that look at, say, Australia, New Zealand, Haiti, Africa, Tanzania, other places that are maybe even more rural, certainly, than many parts of our state. The effective models tend to have what's referred to as comprehensive maternal care that includes the baby, includes the family planning services, a context of the most trusted care source, which might be a lay midwife in an area of Africa, or might be a shaman in a particular community, but the most trusted source of care in that community that can go into a home and involve themselves. They have a sense of the social support, and they build and continue to build and maintain those social supports within the community, not in a separate area geographically, but within that community. They tend to have pre-planned communication with a more definitive, more prepared for emergency source of care that is pre-communicated and networked. And they may have what's referred to often as a shared care model for prenatal care to ensure that the screening and monitoring is done in a manner that is evidence-based and best practice. So that's not to say that all of this must occur for improvements, but in Virginia, in our maternity care deserts, I challenge those on this call to think, gosh, do our maternity care deserts in Virginia have these things? And my guess is certainly not all, and probably not many. And so that's a little bit of a call to order when it comes to these issues with family docs in primary care who could potentially be a part of the solution. We have a framework for preparing This is a common framework used to kind of alert ourselves to situations, pre-communicate, try to get ahead of any resource gaps that we have, and train and practice for all these emergencies that could occur. And an example of how we could potentially approach this could be a health system close to a maternity care desert could reach out to family docs. Family docs could engage with the health system and identify situations that are at special risk. And the health system knows those risks perhaps better than the family doc, but the family doc knows the resource gaps better than the health system. And those comparing and engagement, getting at the same table, could potentially identify some plans for filling those gaps. A discussion on how to proactively communicate with family docs, how far away they are from an ambulance, how far they are away from a labor and delivery, what resources the ambulance in their community has in transporting them, what education their nurses need to provide emergent care, what before the transport, how to do certain drills perhaps to make sure the team at that clinic far away from the health system could improve outcomes. I dare say we don't have much of that occurring in maternity care deserts in Virginia. Family docs who work with EMS all the time to get heart attacks to local hospitals know just how long it takes and know generally the EMS systems. And many of you on this call may not be aware of what that is, but not all ambulances have advanced life support. And even if they have advanced life support, they may not be able to transport the patient quickly. And they frankly may not even have a lot of the neonatal response things in the back of the van. They may not have the instruments that are needed to perhaps deal with bleeding, or even a delivery. The pre-sit pack may not be what you think it is. They likely do not have certain medications to deal with, say, eclampsia with magnesium, or postpartum hemorrhage with oxytocin or misoprostol, all the things we tend to be used to using. And it's important you understand that EMTs are not authorized and frankly not licensed to do a vaginal examination. So they cannot stop bleeding manually with a bimanual exam during transport. So all of these are key things that systems and family docs kind of accommodate for. No matter whether you are a level 1, level 4 maternal care site, or a level 0 in maternity care deserts, imminent and precipitous deliveries can happen. Delivery emergencies can occur because of that, or other emergencies related with prenatal care. And so kind of working with health systems, OB departments, resources of care at labor and deliveries to train and practice for those situations are things that family docs are familiar with, but maybe not expert at, and certainly could be helped. Rural EMS practices do not have, as I mentioned, magnesium that's pre-mixed for eclampsia use, calcium gluconate for reversing that if it gets toxic, or any of the things related with postpartum hemorrhage. And as we all know, the main reason for obstetric-related death in the US is related with postpartum hemorrhage. So kind of getting systems to work with clinics and resources in maternity care deserts in Virginia would go a long way. So how could family physicians help? Well, we could be utilized as well-placed, readily available resources to extend prenatal care and rural incidental, urgent, and emergent care and maternity needs. So I just want you to know that family docs are not the solution. We're not a big number, but we are a great contributor to potential force multiplication. We are the experts in the communities that are maternal care deserts generally, and health systems who may or may not be engaged with those family docs are missing some understanding there. And so that could go a long way. Re-engaging family docs in addressing the gaps in maternity care deserts. There might be some at-risk places that are about to lose a labor and delivery. Family docs could be, just like a nurse midwife or an obstetrician, a good source of filling that gap. And engaging in pre-planning for these emergencies is critical. I hope with this time you've been able to see a few things. I leave a few moments here at the end for questions and hopefully some answers. And I welcome whatever ideas you have, certainly in chat. So I'll turn it over to any chat-based questions. Sabrina?
Sorry, thanks so much, Dr. Gregory. That was awesome. If anybody has any questions, please feel free to send them in the chat. If you can't think of any right now, I can make sure that I pass them along. We're gonna also upload this to our YouTube channel in case you missed anything or in case you want to refer back.
Okay, I'm just looking through chat here just to make sure I'm not missing any questions going back a little ways here. You guys were really paying attention to detail here. I appreciate it all. Yes. Okay, so lots of engagement here. Some questions about advanced life support and obstetrics, and I'll be happy to talk offline. Perhaps Sabrina, you could share my contact information with the group. I'm happy to engage by email or by phone. Advanced life support and obstetrics is a passion of mine, and I'm happy to share more if you want. I'm a resource to you if you're trying to engage with family docs, and appreciate your attention.